Good morning, everybody. Welcome to the June lecture series, a week early, so that Dr. Ganschow can speak to us today. She has been Director of Cancer Prevention and Survivorship at the University of Illinois Cancer Center in Chicago since March of 2021, after 23 years on faculty across the street at Cook County Health. She's an oncogeneralist who trained in internal medicine at Northwestern University and now focuses her clinical care and research primarily on cancer along the continuum of care from prevention and screening through survivorship. She has dedicated her professional life to working cancer control research and education, building innovative programs that enable equitable, high quality access to cancer screening and prevention services for the underserved populations, with a recent focus on embedding cancer survivorship and cancer genetics services into the primary care space. So today, Dr. Ganschow will talk to us about multi-cancer early detection tests. Very excited to hear about this. Go ahead, Dr. Ganschow.
Great, thanks. Before I share screen, I just want to do a couple of introductions because I think we have some new faces in the room here today. And Debbie, thank you so much for letting me switch the Thursday. I'm sure that caused a couple of problems, but I'm out of the country next week and couldn't swing this next week. So thank you all for attending a week early. So I wanted to introduce Dr. Sean McClellan from Family Medicine. He is our new faculty apprentice in the Cancer Prevention and Survivorship Program. So we're going to be now, with support of the Cancer Center training primary care providers in cancer survivorship and cancer prevention through a year-long training program that includes some protected time to come work with us in the clinic, to do some rotations through some of the support services that are available to our cancer survivors throughout UI Health, and then a series of didactics and potentially project work too. So Sean McClellan is going to be our first faculty apprentice. Sean, I don't know if you want to unmute and say anything, but we're really excited. He's starting with us July 1st. So he's starting a little early to come join the lecture series. And hopefully over the next year, we'll also hear him present in the lecture series. So go ahead, Sean.
Hey, yeah, thank you, Pam. I just want to say I'm really grateful to be here with y'all today and to be working with you this upcoming year and to be part of this survivorship community. Yeah, excited to keep learning and do what I can to contribute to the work y'all do.
Great. Thanks, Sean. And Luis Rivera will be our second physician who will be rotating with us starting in September. He's the director at the Wilson Clinic. So really excited to have both of you from Family Medicine. We're also opening up a rotation now that will start July 1st. It's had huge enthusiasm. Dr. Manson, Dr. Owadi are running that. And that's going to be exposing primary care trainees in both family medicine and internal medicine to a two-week rotation through cancer prevention and survivorship. So we're really excited to be able to expand the training of, I think, these important cancer control services into the primary care space, where we don't really get a lot of this in our residency, maybe a little bit in medical school. So I think it's really important to start embedding this in order to have a workforce that's ready to do and take on some of this care. The other face that was in the room, and I think maybe have just hopped off, we also have a couple of students working with us over the summer in cancer prevention and survivorship, 2 DICER students and 1 pair student. I saw Justin was on here earlier, so Justin and Kyla, hopefully they'll rejoin. But we're really excited to have all of them join us over the summer to work on important projects in both spaces. So, okay, and I see Dr. Jimbo joined. Hi, Moss. Thank you for joining. We were just talking a little bit about some of the training that we're going to be doing with the faculty. So we introduced Sean, and also with the rotation for family medicine and for internal medicine residents coming from cancer prevention and survivorship, and really support. I really thank and are grateful to the family medicine department for supporting this and sharing the enthusiasm that we've had for this. So, okay, I'm going to go ahead and share screen. And I was going to talk about models of survivorship care today, but I decided that's kind of a dry topic and may not be completely appropriate for this group. So I've been doing some talks on multi-cancer early detection tests, which I'll talk a little bit about with patients and with providers. And so I'm going to share some real basic information about what MCEDs are, what this terminology is, and walk through that today. And then I'll talk a little bit about one of the studies that we have ongoing at UI Health related to this. So I'll go ahead and share screen and get started. Second, okay. All right, can you guys see my screen? Okay, I'm gonna assume
Yeah.
the answer is there. Okay,
Yes.
great. Second, okay, all right. So I've talked a lot about MCEDs in the context of post-cancer treatment surveillance. And I think these are really actually have a lot of, so there's a lot of work being done to look at these tests that I'm going to talk in more detail about, both in the sort of post-cancer treatment surveillance setting, but also in the cancer screening setting. And so I'm really excited. These aren't quite here yet. They're starting to integrate into the post-cancer treatment surveillance setting, not quite into the cancer screening setting so much clinically, but I think they really have a lot of potential. And so hopefully at the end of today, you'll understand what these tests are and why I'm so excited about these, and hopefully share that excitement. So as I mentioned, we're not quite here yet. So a lot of the technologies I'm going to talk about are not integrated into the clinical care setting right now. But let me sort of walk through these, what they are, what the terminology is. I'm going to talk about them, and I'm going to use the term multi-cancer early detection tests. And when I talk about this technology in that setting, it's really used for kind of cancer screening for multiple different cancers. I'll talk a little bit about what this test is and how they were discovered, which I think helps us really understand sort of how they're used and how they were developed. I'll talk a little bit about the potential to change the landscape of cancer screening with these tests. And I think importantly, and what a lot of the research right now is around in terms of these MCED tests are how we manage the possible test results. So false positives, false negatives, true negatives, and true positives, and what the next steps are in evaluation of a positive test. And I think here I just want to caution us and really I think at the end of this, you'll probably be really excited about this technology, but I think we really need to understand that we need additional research before these are used in a widespread manner for clinical practice in the screening setting. I do think there's some populations that may benefit from that now outside of the research protocols, and we'll talk a little bit about that as well. On the flip side, when we talk about the utility of these tests for cancer surveillance, they're often referred to as tests for minimal residual disease, or MRD. So MCED and MRD, as Debbie pointed out earlier, it's not NSAID, it's not non-steroidal, it's MCED, and they can often sound the same, but multi-cancer MCEDs are really talked about in the terminology we use when we're talking about this test in the cancer screening setting, and then MRD, minimal residual disease test for cancer surveillance in the surveillance setting. The MRD uses a similar technology as MCED, and I'll kind of walk through how it's a little bit different, but using that same technology. And really the utility here is for cancer surveillance or recurrence in patients who already had cancer. And I'll talk about how this is right now being used in a very limited fashion in clinical practice. So we are actually seeing this test done and covered by some insurance companies in this setting. I'll also spend some time talking a little bit about how MCEDs and MRD tests are different from other DNA tests. So I think a lot of people sort of, talk about DNA tests and they get kind of confused about, especially patients, about what these different tests are. So I'll spend some time talking a little bit about what the difference is. And then just at the end, kind of end with, that this is really an exciting science of the near future. We're going to talk a little bit about some of the tests and the studies that are available here. But do realize that for the most part, these aren't quite here yet in clinical practice. We need a lot of real world data before they get implemented into general practice. But I do think they have the potential to dramatically shift the way that we're doing screening. Okay, so that's kind of what I'm going to cover today. So let's just move into the screening test, right? The multi-cancer early detection test. Essentially, this is using a single blood sample, not necessarily a drop of blood, a single blood sample to test for many different types of cancer. So it really has the potential to revolutionize the way that we do screening. And I think one of the ways I explain this to patients, because patients are asking me about this, is to actually go back to how this MCED test was discovered. And so if you think back, myself, I had an amniocentesis when I was pregnant. I don't know if any of you have had that or your partners have had that, but essentially when we were trying to develop non-invasive prenatal tests that didn't require an amniocentesis for everyone to look at the health of the genes of the baby, we realized that, that baby's DNA was actually shed into the maternal bloodstream. And so we could actually do a test of mom's blood to look at the health of the genes of the baby. And so that both mom's DNA and baby's DNA were floating around the bloodstream. When they did this test, they actually found that there was a third type of DNA that was also circulating in the maternal bloodstream, and that was that of tumor DNA. Okay, so they actually found a third type of DNA that was present in about a very small subset of this pregnant population that actually was related to tumor. So asymptomatic pregnant women, they actually found that this DNA was related to cancers, occult cancers that these women had at the time of pregnancy, and they were able to detect this during the test for the fetal DNA. So when they separated out mom's DNA and mom's blood cells, they found the fetal DNA, and they also found a third type of DNA, the tumor DNA. And I think that created a lot of excitement about the potential for this blood test now, this technology, to actually translate into the screening setting to potentially identify patients through a blood test to look for tumor DNA to determine if they had cancers. So why is this important? Well, and how could MCED sort of change that landscape using this technology? I think it's important to know that 70% of cancer deaths, cancer-related deaths, are from cancers without recommended screening options. So for example, I think the ones we talk about commonly, ovarian, pancreatic, brain, and many, many others. We have many organs on our body, but the majority of cancers that are out there today, we don't have screening tests for. And we really, if you think about it, we only have 5 general population-based screening tests that are currently available, and they're listed here. So cervical cancer screening, breast, colorectal, and lung and prostate. So for women and for men, there's only 4 available for each. And so this test has the potential to actually identify over 50 different types of cancer. So some of the tests that are out there right now are checking for and identifying over 50 different cancers. There's others out there that are identifying up to 100 different types of cancers. And I think this is important because many of these cancers that we don't have screening tests for present at late stages. And if we're able to, they're really hard to detect early. And so if this technology is able to identify these at potentially treatable stages, I think there's a lot of potential. And that's where a lot of this excitement comes from. In addition, as I mentioned, if we could detect those cancers early, we can dramatically improve cancer survival. So you can see the survival rate here is almost 90% when cancers are detected early. So if this technology is able to detect cancers at an early stage and otherwise asymptomatic individuals, it really has the potential to save a lot of lives. When cancers are diagnosed late, although I think our treatments are improving tremendously in this space right now, and we're keeping a lot of patients with metastatic cancer, we're able to get them into remission and keep them alive for a lot longer, but the survival rate is still pretty low, right? So we really need to be coming at this at a lot of different angles, not just with treatments that are keeping people alive, but also upstream, trying to identify these cancers earlier at stages when they're much more treatable. We can save a lot of lives. So that's a lot of the excitement around this. So how do MCEDs find cancer in the blood? Well, I kind of gave you a sneak peek at that, understanding sort of how invasive prenatal testing, which was looking for the fetal DNA, picked up the tumor DNA. And so essentially that's what I've depicted here. So tumors are often shedding proteins and DNA into the bloodstream that we can actually identify by separating out in the lab the host or the human DNA and the blood cells from the tumor DNA and the particles that are released into the bloodstream from the tumor. And so I'm going to show you a short video that kind of describes this in a little bit more detail that I actually think, I've sort of described this, I think, pretty simply, but this also does it in a way that I think we can also share with our patients if they have an interest in this and can point to other, of our clinic staff as this sort of makes its way into the cancer screening setting to help them understand how this technology works. So it's just a 3-minute video that I thought was a nice description of this. I'm going to share with you that you can share with others and use for your own resource. So this is actually related to the Galleri test. The Galleri test is the MCED test.
Let's take a closer look at how
It's the MCED test that the Grail company uses. So there's about 20 companies right now that have developed and are in the process of developing MCED tests. And this is talking specifically about Galleri, but it's that technology is the same across all of these companies. So
test works. In order to deliver your result, the Galleri test looks at over 1 million methylation sites in your blood sample.
sorry about that, guys. Hold on.
Using the latest discoveries in science and DNA sequencing technology, All cells in your body, including cancer cells, release DNA fragments known as cell-free DNA into the bloodstream. The DNA from cancer cells is different from the DNA of healthy cells. DNA from cancer cells have specific methylation patterns that identify it as cancer. Methylation patterns also contain information about where in the body the cancer is coming from. The Gallery test is a cancer screening test that looks for a cancer signal shared across multiple cancer types. In a clinical study, the test was able to detect a cancer signal across more than 50 types of cancer. If a pattern that suggests cancer is found, then the Gallery test result would be cancer signal detected. If a cancer signal is detected, the test analyzes the DNA patterns found in the sample to predict one or two locations in the body the cancer signal may be coming from. These locations are called cancer signal origins. This helps your healthcare provider determine next steps to confirm if cancer is present. Keep in mind, the Gallery test does have limitations. Not all cancers can be detected in the blood or by the Gallery test, and false negative positive results do occur. Lastly, keep in mind Gallery screens for cancers that may be present at the time of your blood draw. It does not measure your future risk of developing cancer. The Gallery test is used in addition to and does not replace other cancer screening tests your healthcare provider recommends. If used as directed, Gallery can be a simple way to take a proactive step in knowing more about your health. The Gallery test is prescription only. It is not recommended in individuals who are pregnant, 21 years old or younger, or undergoing active cancer treatment. Gallery does not detect.
Okay, so hopefully that gave you an idea of sort of what this test is about. Gallery is actually, and part of the reason I chose that one is that is the study that we're running here, the real Pathfinder study that includes the Gallery test. So we'll talk a little bit about that at the end, but I want to just move into what to do with a positive and negative test. So they talked about sort of that cancer signal being present or absent, which translates into what we call a positive and a negative test. So I'm going to start out with negative tests. So about 98% of the tests, so in the studies that they're doing right now across populations that are asymptomatic, screening age, we're finding about 98% of the tests are negative. And the majority of these patients don't have cancer, but false negative tests are possible. And I think that, when we define a false negative test, we mean a negative test in a patient who actually has cancer. And in this setting, we do know that these tests can actually miss cancers that are really, really early, because in order for this test to be able to pick up tumor DNA in the bloodstream, the cancer needs to be advanced enough that it's actually shedding, that it's got a blood supply and it's shedding those particles, the DNA and protein particles into the bloodstream. So it can miss a very early cancer that may not have a blood supply or may not be invading a blood vessel. And for this reason, I think it's really important to know that we are definitely recommending, and in all of these studies, these tests do not replace current screening strategies. So these tests may not work as well for things we currently have screening strategies for, although they may pick up things that our screening strategies miss. But I think that, a lot of the excitement is that actually that we may be able to pick up cancers earlier before they present symptoms in the cancers that we don't have screening tests for. So we're looking at it in both of those settings. But I think it's important to realize that you do have to have somewhat of a tumor burden and the tumor has to have access to the blood supply in order for this test to be able to detect that cancer. So false negative results are not that uncommon, but again, the majority of tests are negative and the majority of those are true negative. In terms of a positive cancer signal, and I think this is where a lot of the research is being done, is sort of evaluating what that means. So let's just talk about that for a minute. So again, 98% of the tests are negative. Only about 1% to 2% of the population actually will test positive for a cancer signal. And this may vary by the population's risk. So a population of cancer survivors may have a higher percent of positive tests if they're at higher risk for cancer, as well as high risk populations. What we know now, and again, this number varies by the different companies and the tests that have been developed, but we're finding about 50% of the current positive tests will actually have a cancer detected on additional workup. So there is this phenomenon of a false positive. And I think this can provide provoke a lot of anxiety, and patients need to sort of have eyes wide open when they're going into this test, that we can pick up tumor DNA that actually isn't cancer. An example, a classic example of this is fibroid tumors. So some women develop fibroid tumors throughout their lifetime, and so it can pick up tumor DNA from tumors that are not cancerous. Okay, a fibroid is a classic example here, but there are other types of benign tumors that again, if they're really proliferative and they're shedding a lot of cells and DNA into the bloodstream, we can pick that up as well. So not every positive means that you have cancer, which actually, and again, the test itself is not diagnosing cancer. It's telling us that there may be a cancer that requires further workup. So, the follow-up testing that needs to be done to evaluate positive tests, I'll talk a little about in just a minute, but understand that the risk of false positives, and I mean here a positive test in a patient that has no cancer detected. What we're finding through some of these studies is that those patients, as they're followed up over time with additional testing, if additional testing doesn't find a cancer over the next year, that the risk of having a cancer goes back to sort of general population numbers. And again, this is where some of the research is being done. So I'm not sharing a lot of that data, but I think that's where what we really need to see in order to bring this into the clinical space is what that workup is and what that future risk is of cancer once a positive signal is detected. So those patients are being followed, and in our trial here, they're being followed for 3 years if they have a positive test. As well as if they have negative tests to determine if they develop cancer. So really figuring out how that, what the sensitivity and the specificity of this test is, and understanding what that diagnostic journey is after a positive test, and what those cancers, how early those cancers are detected if they are detected after a positive test. The other thing that I just want to mention is that the GRAIL test, the one that you just heard about in the video, also when they do this test, they're able to look at those methylation patterns and help determine where that cancer may be, so that we're not doing necessarily whole body scans on everyone for a positive test. But some of these companies that are developing these tests are able to look at methylation patterns that can help determine where that additional diagnostic imaging needs to focus. So for example, if you have a positive test that says maybe this is in the breast or in the pancreas, you may have additional imaging with like a mammogram or an MRI. Or if it's somewhere else in the body, you may need a whole whole body PET scan from head to thigh, or you may need a CT scans or MRIs of specific parts of the body. So the diagnostic journey here is, I think, again, part of where we really need a lot of research to inform what we do next and how we standardize what that testing process is going to be. There are companies like Exact Science that have an MCED test that detects over 100 different cancers, and it doesn't give signals as to where that cancer might be. So in those settings, they're looking at the utility of whole body MRI and whole body PET scan. So again, this is not going to hit prime time until we really understand what that diagnostic journey involves and what the risk of cancer is if we don't find anything on initial imaging, and what that close follow-up looks like. So a lot of research to be done for what I like to call real world research in terms of how we actually operationalize these tests and what the follow-up testing is at least needed. So I'm going to just shift gears a little bit. We talked about MCED. We talked about this technology in the cancer screening setting and its potential, and where we are, today in terms of research around this. We still have a lot more information to gather before I think we make that prime time. But what about in the cancer surveillance setting? Can this new technology also help detect cancer recurrence during surveillance? And the answer is yes. So this is what we call the minimal residual disease test. And this is really focused on just detecting one cancer, the cancer that you've already had. It's really about using the same technology to identify whether your cancer has come back. Okay, so it's not the 50 cancer panel. This test is just looking for the DNA from your original tumor. And it is used, as I mentioned, in the clinical setting for very high risk for cancers that are really high risk for recurrence. In addition to also telling us if that cancer has come back, it can also help determine if and what additional treatments may be needed, or if the current treatment is working. So again, here is just a little bit more detailed. So you actually take a sample of the tissue, as well as the blood, and then you determine actually what the signals are for the cancer that you have, so that you can pick up that DNA in the blood. So specifically looking for that DNA from your tumor, and also looking for how those potentially mutations in that tumor are changing that may help drive treatment. So I think it's a really important technology. It's shifted a little bit to just sort of focusing on the cancer that you had, not to the screening for the 50 different cancers, but really can help us, I think, identify cancers that we may not be able to pick up that have recurred on imaging. So we may not be seeing it on imaging, but it may be sort of what we call a biochemical recurrence. We're seeing that tumor being shed in the blood. We can't find it necessarily, but we can also determine how to treat it based on how it's changing over time. So I just want to go back and talk a little bit about technology. So people are like, well, what's liquid biopsy versus MRD versus MCED? Are they the same thing? I think I've helped you understand the difference between MCEDs and MRD, again, using that same technology, but in a different setting and looking for a different number of cancers. Liquid biopsies, when we talk about that terminology, think about liquid biopsies as sort of the umbrella term. So MRD and MCEDs are all different types of liquid biopsies. Okay, but MCEDs then used in the cancer screening setting, MRD used in the surveillance setting, liquid biopsies being that umbrella terminology for all of these types of tests. So how are MCEDs and how is the MCED test, the MRD test, how are these tests different than cancer genetic testing? So all of these involve looking at the DNA, but cancer genetic testing really looks at the DNA and the genes that you were born with. So this is actually looking at your own DNA, not the tumor DNA, but the DNA that you, your own DNA, to look for mutations that may put you at risk for cancer, for a wide variety of different cancers. It really helps answer the question, am I at risk for cancer, or is my patient at risk for cancer? Or why is cancer running in the family? Okay, this is very different than the MCED test, which is actually just looking for tumor DNA in the blood and particles from the tumor. That helps answer the question, do I have cancer right now, or has my cancer recurred? Okay, so I think this is important, and I think our patients may not understand because they think about it all as a blood test, right? So, you know, helping them to understand what it is, what test we're doing, and what information that test is providing. Because in some settings, both types of testing may be indicated, where in some settings, like in the recurrent setting, for a patient that may not have a strong family history or early age cancer, may just benefit from something like an MCED or an MRD test. So when will these liquid biopsy tests, these MCEDs and MRDs, be available to the general public? Well, I think, as I've mentioned before, we need population studies before this test is really recommended for widespread screening. We need participation in research studies that are planned, and the NIH has a number of the Vanguard studies that are planned and will probably roll out in the next year to 2 years, but may not give us information for another 5 to 7 years, as well as many of the ongoing studies that are being done by many of the companies that are trying to develop these tests. The frequency of testing, so how often this should be done in different populations. So should this be done every year, every 2 years? You know, are we getting this at the same time we're getting our mammogram for women, you know, age 40 and over? Is really unclear. And I think that this is what some of the real world clinical trials are going to help inform us. Do high-risk populations need to have these more frequently? Do our cancer patients where we're doing this and they're looking for the recurrence, you know, what is the right pattern and frequency of testing that needs to be done for those patients? So I think a lot of our trials are going to help inform us around this. But nonetheless, I do think MCEDs provide, you know, really a glimmer of hope for detecting many cancers that currently have no screening tests. And until then, we may see clinicians, and I know that this is happening out there right now. This is not covered by insurance because we don't have any guidelines, because we don't have a lot of research to guide this. But that some patients, some clinicians are offering this for their higher risk population. So potentially those patients that may have a hereditary cancer syndrome or other high risk or are otherwise at high risk for cancer, you know, may they have a strong family history of cancer or already have dysplasia. The clinicians are talking to them about this test. They do have to pay out of pocket. It is not covered by insurance in this setting. As I mentioned, we have no guidelines around this. In addition, patients, you know, our high-risk populations who already had a prior history of cancer can also consider this, but again, need to pay out of pocket. And then patients who've had environmental exposure. So patients who've had a history of cancer or are at high risk, there are some clinicians who are starting to talk to patients about this test, but understanding we really don't know what that diagnostic journey looks like. We really need a lot more information before this goes widespread. So they need to go into this with eyes wide open. And in addition, understand that there is a pretty high out-of-pocket cost. So right now it's somewhere between $900 and $1,100. Most of these tests, as I mentioned, are not covered by insurance, although MRD in the high-risk recurrent setting may be covered, and we are seeing this used a lot more in that setting. There are no guidelines, as I mentioned, for utility of the MCED sort of in a population screening setting or for follow-up testing. But there are many tests under development now and a lot of research happening in this space. So I think in the next 3 to 5 and potentially 10 years, we're going to have a lot more information, and we may be really shifting the landscape of the way that we do screening. So finally, I promised I'd talk a little bit about some of the trials that we have underway. So we are actually at UI Health, the only site for the GRAIL Pathfinder 2 study, which is looking at the MCED test for cancer screening in a general population. And this includes patients who are potentially at average risk for cancer or at elevated risk for cancer, or who have not had cancer in the last 3 years. So patients who are of screening age, so this is 50 to 79, can enter this study. And essentially they're doing one MCED test and then following the patient with questionnaires, telephone-based surveys over a 3-year period to understand what happens to patients who have a positive test. And this GRAIL study will actually cover all of the additional testing that's needed if you have a cancer signal detected. So if you have a positive test, they'll cover all of the tests that you're needed to evaluate whether or not you actually have cancer. And then if you're diagnosed with cancer, then your insurance takes back over for the treatment of those cancers. But really exciting. We have been a site for this trial for over a year, and we are going to stop enrollment in mid-July. So if you, this is open to employees, but also to our patients, want to refer patients to this, we are going to be, recruitment is going to end at the end of July. We are the only study site in Illinois, and GRAIL is really interested in actually getting men enrolled in this trial. So we have a lot of women. There's not great representation from minority populations. So UI Health is really focused on helping them accrue men and accrue minority patients into this trial. So if you have patients or you're interested in learning more, please let me know. I can answer questions about this, but we do have still about a month left to enroll in this trial. And the trial will continue for about 3 years. So the test will be done once, and then they'll do these surveys for about 3 years to follow patients and understand what that diagnostic journey is, and also understand, for patients who have a negative test, looking to and following them to determine if they actually develop a cancer. So how well this test is working in terms of its sensitivity and its specificity, as well as the diagnostic journey that follows. So I'm going to stop there. I just want to end with, I think we are on the major precipice. We're on the precipice of a major transformation in cancer screening. I think this MCED test holds a lot of potential in terms of us being able to detect, especially cancers that we don't have screening tests for now, hopefully at an earlier stage in the future than they present currently with symptoms. And I'll stop there and answer any questions.
Thank you, Dr. Ganschow. That was so interesting. It's going to be really interesting to watch the landscape of this whole thing changing before our eyes, for sure. Yeah, I've heard a little buzz about this. My husband knows into health and longevity, and he does a full panel of lab tests. And he said the lab tests are through Function, which is Mark Hyman's company in functional medicine. And Mark Hyman, some of those doctors are already doing the Gallery test for all their patients. But yeah, it's expensive. It's
Right.
almost $1,000. So hopefully we can make some strides in improving insurance coverage for this. And yeah, I would join that trial if I was a little older.
I know, unfortunately, it's at 50, even though many of our screenings start at 40,
Right.
everybody, right? So right now the lower age limit is 50. I'm not sure about the age limit for other studies, and I don't know what Vanguard is going to use. Potentially, I think it's going to include a wider range of populations to understand how we use this, even at earlier ages. So
Yeah, you're right.
There are a lot of people who are going and paying out of pocket for this, and there are some providers, especially those that work with high-risk populations, that are offering it to everyone. I'm not sure we're quite ready there, and I think people really need to understand we don't have a lot of research in terms of what that diagnostic journey looks like. So I'm a little hesitant to actually roll this out with all of my populations, but I think in our high setting, right now we have an opportunity to enroll those patients, in the Gallery trial and Pathfinder trial.
Yeah.
So
Well, yeah, we know so many
more research.
patients so many patients are like very emotionally tied to this, right? Having a lot of family history, or like I have to know because all my aunts had this cancer. So there's going to be probably, despite the cost, you're right, lots of interest in this.
Yeah, well, it's interesting. I did talk with a patient last month about this, or a couple months ago, and she looked at me. I kind of walked through the whole thing, and I think for patients sometimes, you know, they don't always understand how this test is done, and using that, like telling them how it was developed, helps them kind of understand that a little bit more. But anyway, I talked to her about this, and I said, you know, is this a trial you'd be interested in joining? And she's like, Doc, I thought you were doing this test on me all along when I had my blood draw. So, you know, there's a lot of misconceptions about what it is that we
Right.
actually draw blood for, right? I mean, it's sort of like, oh, we're testing for everything. And, you know, we don't talk to them about exactly what we do. We're like, you're due for your blood, you know, your blood test, you're to check for diabetes and everything else. But I think a lot of patients think that we actually are doing this already, and we're not. So.
Right. Does anyone have a question? Sean, did you have a comment or
Yeah, I
question?
had a question. I think for like, I was wondering like for the, you mentioned that like the residual disease testing is just focused on like one cancer type, whereas like the early detection is focused on like 50 cancer types. But I know like we do a lot of like screening for like every type of cancer and cancer survivors as well. And I was just looking like at the inclusion criteria for the trial, and I think it looks like they're just focused on people without a history of cancer. So I was
No, no,
curious if you
no,
knew.
no, you can be in there as long as you haven't had cancer in the last 3 years. So they are
Oh, okay.
cancer survivors. Absolutely.
Oh, okay, interesting, cool.
Yeah, really
That's what I was
important.
wondering
And a
about.
lot of our, we've actually been offering this in our cancer survivorship clinic to patients, right, who have that concern, but they have to be
Who's
3 years cancer free. And they can't, you also can't be undergoing a diagnostic evaluation from any abnormal screening test. So if you've had, you know, an abnormal mammogram and you need a biopsy, you have to wait till after that biopsy to enroll. So, yeah, and I think that's a really important population to include. I think the Vanguard study will also include our cancer survivors. We need to understand how this test functions, right? Because patients who have one cancer are higher risk for another cancer, right? So thinking about them as a high risk population, we need to understand how the test functions in that space.
Hmm.
Who's in charge of the study at UIC? Do you know?
Yami, and VK.
Oh, Yami. Oh, cool. Perfect.
So, and we actually, she's got a research assistant that's going out to the back of the yards clinic right now, to do some targeted recruitment for some of our minority populations. The test, you know, it does require a blood draw that our clinics can't really support. So patients do have to go with, do have to get their blood draw, which they can do over in the SRH building. So, if patients are interested, they can call that phone number, or if you're interested, if you're of age and you want to join this trial, you call that number and they'll do a quick eligibility screening with you, and then you come in for a blood draw at the cancer center. But it's just one time, even though you're followed for 3 years. It's not like a yearly test or a 6-month test. It's a one-time blood draw with a 3-year follow-up.
Yeah, and even though a test might be negative 1 year, it's not to say it won't be positive in a year or two. So that's another thing about insurance coverage. So, I mean, I think the aspiration probably is to do this as an annual blood work, or annual blood work to do this test, right?
Yeah, I mean, we don't know that right cadence, right? It may be 6 months for our high-risk patients, right? Or, you know, at some other interval, right? Yearly is sort of what we're stuck with and what we've developed for many of our cancer screening tests, but I'm not sure that's going to be the right interval for everyone. So maybe individualized for different populations.
Yeah, it's
In
definitely.
the MRD setting, for some of the patients that have a high risk of recurrence, it's being done, you know, every couple of months.
Mhm, for sure.
There
Anyone
was
else?
a question about, I will absolutely attach the Grail flyer, and I can do that in English and Spanish with the PowerPoint. So thank you.
Anyone else have
Hey
questions?
Pam, it's Vivian. I was wondering, do you think the counseling for this test, do you think
Hmm.
do you think there's any lessons that we can learn from other things? Do you think it'll be similar to how we, like if the results come back, how we counsel for other kind of screening tests, and how we explain this test to patients? Do you feel like it's the same way we would talk about, say, a mammogram, or do you think it's really kind of different?
Yeah, you know, I think that's a really good question. You know, so counseling someone who has a positive test, is that kind of what you're talking about. I mean, really positive or
Mhm.
negative, right?
Right.
You know, I think that we do need to caution patients that if it's, so I think there's some important counseling. I'll start with negatives. And I think one of the fears that people have is that somebody might get a negative MCED test and say, well, I don't need my mammogram this year. Or I don't need my colorectal cancer screening, right? So I think we really need to focus on providing information to patients and providers providing information to patients as this rolls out into the real world about, you know, the potential harms of a negative test in terms of not complying with screening. So I think that's an important piece of counseling. I think the positive, you know, the positive cancer signal, the positive test also is going to need some very careful counseling, right? And that, and even counseling about this to set expectations prior to the test being done, is that if this test is positive, it doesn't necessarily mean that you have cancer. It just means we need to do further investigation. And that isn't, you know, that different from, you know, potentially what we do like with a mammogram, right? So somebody gets a mammogram and it's abnormal and it's graded, right? We've got the BI-RADS score that help us understand the risk of malignancy, right? But that often, you know, you have to take next steps. We need to either do a biopsy or we need to do additional imaging using that kind of that same principle for counseling for, you know, and for setting expectations prior to going into this test is if you have a positive test, right? It doesn't mean you have cancer. This is not a cancer diagnosis test. This is a screening test and we need to do additional evaluation. What that additional evaluation looks like, you know, and preparing patients for the fact that they may need to get a whole body scan or they need to have screening of several different parts of their body, right? As that follow-up and potentially a biopsy. I think some of the good information that I'm starting to see from companies, and I mentioned this earlier, like Exact Sciences, is that what we're seeing is that if patients have a positive signal and they have negative follow-up imaging, and I don't know over what period of time, I don't know if that's 6 months or a year, but that risk of having a cancer actually goes back down to kind of the population risk, which is about 1%. So this isn't a signal that if we don't find anything over a year, that there's something hiding there that we can't detect. It looks like if that follow-up imaging is negative over a period of time, that we can reassure patients that it's unlikely that they have cancer. So Vivian, I think people like you and our genetic counselors are probably the most well-versed to do this, right? And that there may be a real role for the genetic counselor down the road to help counsel around the positive cancer signal, you know, and help patients through that diagnostic journey. And I don't know if you want to add anything to that, because I know that you're probably share a similar passion with me for these tests.
Yeah, no, I absolutely do. And I would just say, like, part of it is like we've sort of done this before, right? Like you said, this technology came from the NIPT setting. So I think we can learn along from that setting. Granted, pregnancies are different than cancer for sure, right? And so, but I think there are tools that exist, and I think finding similarities with other cancer screening modalities too is really helpful. But I think we need to be really thoughtful in terms of like how we talk about this with patients and how we help them make informed decisions. It just yeah. And I think as this coming, it's confusing, right? Like you said, like what's liquid biopsy versus MCED versus MRD. And like, then you add in genetic testing and everything's about genes. And so it's just, how do we use the right terminology so we're not confusing patients? A lot of my patients like, oh yeah, no, I had a genetic test. It's like, nope, you didn't. That was something else. And a blood test is a blood test. Now we're calling a blood test a liquid biopsy. Like, it's just so confusing. And I think there's also a need to think about how we're communicating with this. So yeah, but no, and I think I agree with you. I just share the same passion. Like, no, it's not just the technology is super cool. There's no questions about it, but like, how do we help patients make the right decision that's aligned with their values, right? Yeah.
And I think research is going to inform the conversations that we have. I will tell you that there are organizations right now that are trying to stay ahead of this and help patients, provide patient-friendly information that can help educate them and help educate potentially navigators, right? That may be helping me. You know, we're using navigators to help with patients who have abnormal screening tests right now, right? So we have lung cancer screening navigators who help patients with abnormal tests get through that process. And so I think developing information that can help inform and educate our navigators that potentially will help patients through this test and through that diagnostic journey is going to be really important too. As well as, thinking about what that patient journey is and helping patients with information at every step along that way, including a negative test and a positive test, right? So, but you're right, we can learn a lot from what's out there right now, the NIPT and the cancer screening setting. So thank you, Vivian, for that great question.
Oh, we got another question from Teresa in chat. What support is being provided to patients when delivering a positive test result? Are we asking them to be accompanied by someone else to their appointment? Or asking a representative from Wellness House to participate?
Yeah, that's a great question. Thank you. I think that this is really important. And this is what we're trying to get in front of with patient education materials and for education for someone from Wellness House or a navigator that may be helping patients through this process. We really need to, we need research to help inform that conversation, and we need to think really carefully about that conversation and how to put this in lay terms so patients understand and they don't get overly anxious about a positive test and what that follow-up and that diagnostic journey looks like. So I do think that you're right. We also, and I think this is something we need to improve upon in all of our cancer screening tests, is saying, okay, if you're at that point where you're having a biopsy or you're concerned about a positive test, how do you want that information? Like, do you want us to call you? Do you want to come in for that? Patients have different, I think, different preferences for how they want to get the results of their cancer screening tests. And I think that's something that needs to improve across, as I mentioned, many screening tests, right? We're calling patients, to let them know that their biopsy results were positive and they may be at work or in the car, and that's just not appropriate. So I think we need a lot of improvement in the way that we're communicating around these tests, and this test included. So thank you, Teresa, for that really important conversation. Great question, excuse me.
Anyone else have a comment or question about these cool new tests? We'll see how they unfold. Great. Well, thank you so much, Dr. Ganschow, for telling us about this new stage of cancer screening that's on its way. And thanks everyone for coming a week early. And we will see you next month.
Hopefully I can come back in a year and share a lot more data with you. So
Yeah.
it's just the introduction. So thank you, everybody.
Thank you, Dr. Ganschow. All right. Bye, everyone.